The following episode is brought to you by the American Urological Association. This episode features content from the AUA 2025 meeting in Las Vegas. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. Support has been provided by independent educational grants from Blue Earth Diagnostics, Inc., Lantheus Medical Imaging, and Novartis Pharmaceuticals Corporation.
Okay, welcome everybody. People are still coming in, but we'll start on time, being respectful. I want to welcome you to our course on the integration of biomarkers, MRI and PSMA PET imaging in the management of prostate cancer, which is a presentation of the AUA and Office of Education and Research, Inc. We strive to offer outstanding educational courses, and we really greatly appreciate all you coming. This is actually supported by Blue Earth Diagnostics, Lantheus Medical Imaging, and Novartis Pharmaceutical Corporation. I would like to thank the faculty for their time. I appreciate them coming. The first person is Dr. Stephen Rowe. He is our imaging guy, and he is currently a professor at UNC, formerly of Johns Hopkins. Second is a good friend of mine, Dr. Rob Reiter, who's the Bing Professor of Urologic Oncology in the Division of Urologic Oncology in the Department of Urology at UCLA. And importantly, he is the principal investigator of the UCLA prostate cancer spore. And lastly is Dr. Evan Yu, our medical oncologist. He is at the Fred Hutch, as well as University of Washington, UW. He's a professor at University of Washington, as well as the medical director of the clinical research at the Fred Hutch. And it really is a privilege to be on this podium with all of them. At the end of the program, please take a moment to complete your course evaluations. I know this from experience because I'm actually fortunate enough to help plan a lot of aspects of this meeting, and we do pay a huge amount of attention to those course evaluations. So if there's stuff that you like, please say so. If there's stuff that you don't like, please say so. And if you have suggestions on how to improve it, this is a good time to do it. We'll get into it right with Dr. Rowe. You want to come on up while they're loading the slides?
All right. Well, thank you all for being here, and it's certainly a pleasure for me to speak to you this afternoon. I do want to particularly recognize the organizers here for their insight into the fact that we're at sort of an inflection point with PSMA PET. We know a lot about the sensitivity and specificity of this modality for a lot of different disease states within prostate cancer and how it can be used to select patients for everything from metastasis-directed therapy to radioligand therapy. But beyond that, there truly are sort of imaging biomarkers kind of buried within the imaging data that we've only begun to scratch the surface on, and so that's what I want to focus on today. But I'll lay the groundwork a little bit with maybe some of the data from pivotal clinical trials, and then we'll get into what some of those biomarkers might be. I do have at least one relevant disclosure. That's that I've received research funding and have a consulting agreement with Progenics. So what is PSMA? So I suppose on a biological level, it's a transmembrane carboxypeptidase. It's highly expressed on prostate cancer cells. It has expression in prostate cancer tumors that's probably around 95 or 96% in the primary setting. So there are non-PSMA expressing prostate cancers, but they do tend to be uncommon. And there's been at least a described correlation at the histopathologic level between PSMA expression and the levels of tumor aggressiveness. So for instance, people have described that with higher PSMA expression, there's a higher level of nodal involvement at the time of initial diagnosis. I don't know that we always appreciate those findings at the scan level, which is a more macroscopic level of disease activity in the patient. And here's just a cartoon representation of PSMA. So it has a large extracellular domain. That extracellular domain allows us to leverage the binding of small molecules or peptides or antibodies for both imaging and therapy. And we at least think we know a few things about PSMA PET so far. And I think these points will become more relevant over the next few slides. But and the first point might be one of the test questions that you'll all be taking a post-test on here in just a minute. But moderate sensitivity and very high specificity for preoperative nodal staging. That there's a high detection efficiency for sites of biochemical recurrence, and that we believe PSMA PET is effective for selecting patients for PSMA-targeted metastasis-directed therapy as well as radioligand therapy. And here's just an example of sort of what PSMA PET has kind of allowed us to do in the 4 or 5 years since things started to become FDA approved. So these patients were both Gleason 4+4 equals 8, NCCN defined high-risk prostate cancer patients. And they were both clinically localized at the time that these images were taken on the basis of their bone scans and contrast-enhanced CTs of the abdomen and pelvis. So neither of these patients had any evidence of disease outside of the prostate. And again, they were both Gleason 4+4 equals 8. Yet the patient on the left, after his PSMA PET scan, is still clinically localized, doesn't have anything outside of the prostate that we're able to visualize with the sensitivity of PSMA PET, whereas the patient on your right has not only disease in the pelvis, not only disease in the retroperitoneum, but also has a left supraclavicular lymph node. So he has systemic disease. He has metastatic disease that we can only appreciate on the PSMA PET. So in the pre-PSMA PET era, these patients are probably given exactly the same treatment options, radiation plus ADT or surgery, whatever the case may be. After PSMA PET, in the post-PSMA PET era, guy on the left probably still gets those options with the recognition that PSMA PET isn't perfect and that he may need additional therapy after what his initial therapy may be. The guy on the right is systemic disease and is going to be treated on a palliative paradigm, presumably for the rest of his life. And that all led to a number of clinical trials in the sort of the phase 3 setting, looking specifically at sensitivity and specificity for pelvic lymph node involvement at the time of initial staging. And you know, this is probably a point where I would, in a different context, I would sort of berate you with the idea that, again, there's a very high specificity for pelvic nodal involvement on the basis of PSMA PET findings. There's a relatively modest sensitivity for detection of pelvic nodal disease with PSMA PET. And I could probably bludgeon you with various aspects of how that should approach how we read these scans. But what it implies more deeply in terms of a biomarker setting is that we can potentially sort of define patients in two relatively co-equal patient populations on the basis of their PSMA PET scan findings and on the basis of other information such as their Gleason score and their PSA levels. And those two patient populations are patients that are N0 on scan, but N1 at pathology, because again, we have a moderate sensitivity. So we're going to miss a fair number of patients that are N1 on the scan, but it'll ultimately be N1 at pathology versus patients that are N1 on the scan and N1 at pathology, where the scan and pathology are concordant. And we might say that, well, you know, both those populations are N1, perhaps they have fairly similar outcomes. It turns out they don't have similar outcomes at all. Those patients that are N1 on the scan and N1 at pathology have fairly significantly worse outcomes than patients that would be N0 on the scan but N1 at pathology. And this probably gets into things like the volume of nodal disease involvement that they have and other aspects like that. But what it shows us is, and this would be one of my take-home points, is that a negative PSMA PET scan in terms of nodal involvement in the pelvis is a positive biomarker for patient outcomes. So if you're N0 on the scan, you have a very good chance of having a markedly improved outcome in terms of your biochemical progression-free survival than if you're in one on the scan at the time of diagnosis. I think this is metamorphosed into something where, quite honestly, at a lot of centers, patients that are now in one on PSMA PET aren't really being offered surgery to the same extent that they were before. And I'll defer to my colleagues up here as to whether that's their practice at their centers. But what I'm seeing at my center is people believe this so much that they don't think those patients are necessarily as good a candidates for surgical intervention as perhaps they would have a few years ago. All right. Well, if we're good in the primary setting, we're probably also pretty good in the recurrent setting. So if we take patients who have a rising PSA after an attempt at initial definitive therapy, we know that CT and bone scan are horrible in that setting, to the tune of single-digit percentages in terms of detection efficiency. And we also know that AXAMEN sort of pointed us in the right direction for trying to find where the disease was in these patients, but perhaps isn't as good as the PSMA PET radiotracers that have come into vogue. So here's a patient who was post-prostatectomy, had a rising PSA, didn't have anything on CT or bone scan. We scanned him. We thought we saw something hiding behind the bladder. I think I was like a second or third year resident at the time, and PSMA PET was in its early days, and certainly no one believed me as a second or third year resident, but also no one believed the attending who was overreading me on the scan. So we got a contrast enhanced multiparametric MR, and you can see the T1 post-contrast enhanced image in the lower right there. That did show that there was an enhancing lesion posterior to the bladder. So this patient got salvage radiation therapy, at least partially on the basis of the PSMA PET scan findings, and at least partially with an added degree of confidence that this was the right thing to do for this patient, despite the fact that they had nothing on their CT or bone scan. While a local recurrence is a fairly common finding on PSMA PET, the most common finding in this patient cohort is going to be one or perhaps a couple of pelvic lymph nodes. And you can see that here in this patient. There's a lymph node here. It's a little bit too posterior to be ureter. It's hard to see this lymph node on the CT. It's a couple of millimeters. But the contrast resolution of PSMA PET is such that we can often find these kind of very, very small volumes of disease in these patients. This, of course, also led to the design of multiple clinical trials, Condor, Spotlight, et cetera, that have tried to sort of winnow down on exactly what the utility of PSMA PET is in the post-initial definitive therapy biochemical recurrence or perhaps biochemical failure more broadly setting. And if we think we're good at finding sites of recurrent disease, or I suppose if you think we're good at finding disease both in the initial staging setting and in the recurrent setting, that opens up a lot of possibilities in terms of both synchronous and metachronous low volume metastatic disease and what we might be able to do for those patients who present with that disease state. I will note that when you take an overall look at the this is Condor data, but it tracks fairly closely with the other sort of pivotal clinical trials in this setting. There's a remarkable correlation between detection efficiency and PSA level, which isn't all that surprising. Higher PSA should be higher volume disease, and we should have an easier job of finding that disease. But there isn't such a strong correlation between what in Condor was called the correct localization rate, or CLR. In Spotlight, this was the correct detection rate, or CDR. But what all of these things sort of winnow down to is these are positive predictive values at the lesion level. So we have some sort of finding on the PSMA PET scan that finding is a lesion, and that lesion can subsequently be proven through some sort of hierarchical standard of truth that that's a real finding of disease. that positive predictive value at the lesion level, while there's a little bit of a trend towards a higher PPV at a higher PSA level, it's not all that strong. So what this means is, or at least what I think it means, is that you obviously want to know what the PSA level is before you approach a scan to know what the likelihood is that the patient's going to have a finding on that scan. But if you have a finding on that scan that makes sense with the site of prostate cancer, a pelvic node, maybe a bone lesion in a patient with a rapidly rising PSA, whatever the circumstance may be, that the positive predictive value for that lesion at the lesion level is robust to your PSA level. So if we extend that into our space where maybe we're treating these patients with metastasis-directed therapy, we should understand that PSMA offers us the best sensitivity for finding lesions that may be amenable to metastasis-directed therapy, but also that those lesions individually have high positive predictive values for being true positive. And this is post hoc analysis data from the Oriole trial. Apologize, I was, as was mentioned earlier, I was from Baltimore, so that's the Oriole trial did take place in Baltimore. There is a follow-on trial. It's called the Ravens trial, so I apologize for that as well. Hopefully that trial will be a little bit more positive than the Ravens' last few football seasons have been. But nonetheless, although we like our birds in Baltimore, I think this post hoc analysis data is very key, again, along the lines of thinking about imaging biomarkers. So if we take all the patients who have findings on CT and bone scan indicative of oligometastatic prostate cancer, and we treat those patients with metastasis-directed therapy, and this trial was quote-unquote randomized to either metastasis-directed therapy or observation, but it was also a crossover phase 2 trial, so all the patients who were observed, of course, immediately progressed and wound up on the metastasis-directed therapy arm. But if we take all those patients and we say, okay, let's look at the patients whose findings on CT and bone scan corresponded to their findings on PSMA PET, and we treated those patients on the basis of their CT and bone scan findings, those patients actually do really well in terms of radiographic progression-free survival and distant metastasis progression-free survival. Whereas if we take the patients who had additional findings on their PSMA PET scan, those patients fall off a cliff. Because of course we left sites untreated because PSMA PET scan is more sensitive than CT and bone scan. So there were additional sites of disease that were found. Those weren't necessarily incorporated into the radiation plans, and so those patients didn't do as well. So again, PSMA PET here, it's an imaging biomarker for how we should define the extent of disease and what our confidence should be in whether patients are going to substantively respond to metastasis-directed therapy. Now, I'll sort of rush through the next few slides because they all sort of tell the same point. But when we start to look at systemic therapies and we start to try to follow them with PSMA PET, we see a lot of really interesting patterns, and we don't necessarily know exactly what to do with them yet, but there's undoubtedly imaging biomarkers kind of buried in the changes that occur in PSMA PET upon the initiation of systemic therapy. So in some work from Tom Hope's group at UCSF, if you take a patient, you start them on ADT, there's at least some biology behind the idea that interrupting the androgen signaling axis actually leads to increased PSMA expression in individual tumors, or at least at the individual cell level. So you get this potentially heterogeneous flare phenomenon where while you're killing the cells, you're also driving their expression of PSMA. So there may be a window within which you may see improved, or I should say increased PSMA expression in sites of tumors, and you may even see new tumors that weren't visible prior to the initiation of ADT. The same thing, because this is an androgen signaling axis phenomenon, abiraterone, enzalutamide, darolutamide, apalutamide, whatever, are going to show similar effects. But it's a heterogeneous flare phenomenon. So some tumors will get hotter, some tumors will get colder, some will disappear, some will appear. it's impossible to predict, at least with our current understanding, which of those things is going to happen. But we can at least postulate that there may be sort of whole body tumor metrics that are associated with what we believe the patient's response is. We can track that with PSA, we can track that with time to therapy change, and we can track that with overall survival. And that's maybe the key thing. This is a small number of patients, but you can stratify patients to overall survival strata on the basis of the changes in their overall tumor PSMA uptake from baseline to after the initiation of androgen axis targeted therapy. We can also find early sites of progression. This is, again, super small number of patients, a total of 6 patients. These are all guys undergoing bipolar androgen therapy. And some of them showed, after a couple of months, new sites of uptake on their PSMA PET scans. Others of them didn't. If you look at the ones who showed new sites of uptake on their PSMA PET scans, those eventually became new sites of sclerosis on CT or new sites of uptake on bone scan. But you can find them earlier with PSMA PET, and you can do a better job of sort of stratifying those patients as early progressors on the basis of PSMA PET relative to our conventional imaging. I want to talk very briefly about radiomics and, of course, about AI. I will, of course, get to AI because that's the elephant in the room, if anything is. So radiomic features and likely AI deriving features from PSMA PET scan findings are probably very dependent on high-frequency features embedded in the PET scans. And the reason that's a problem is that PET is intrinsically not a high-frequency feature associated modality. So PET is going to be very good at low frequency features, broad things, quote unquote heterogeneity, things like that. PET's going to be very good at that. But when you start looking at things like these very fine-tuned radiomic features, there are sites within the PET reconstruction matrix that are inestimable parameters, and they require basically nonsense numbers to be put in so that the reconstruction can happen. Those things will never be repeatable. And if your radiomic features are based on those things, they will never be repeatable. And that tends to be true with radiomic features. So very few of them are actually repeatable on PET, and that goes for PSMA PET. And if we look at AI, and I don't think I'm out of a job quite yet, just because I think, man, there's like lots of other jobs that would be easier for AI to do than hopefully what I do every day. We're hopefully in this era where radiologists are being sort of leveled up by AI. But AI is pretty good at finding hotspots. It's pretty good at finding things that just require a lot of attention. But in data that I won't show you here because it's still under review and isn't published yet. But AI-derived segmentation data from PET, including PSMA PET, is also not very repeatable, especially when you get down to small and subtle lesions. So we still have a long way to go to kind of teasing out these like high-frequency, fine features from PET that may be prognostic, that may be hidden imaging biomarkers, but we don't quite understand them as yet. And with that, I'll wrap up by just saying, so again, I want to emphasize this is one of the questions that y'all are about to answer again. PSMA PET moderately sensitive, highly specific for sites of prostate cancer involvement, particularly in the primary setting. And there's a great deal of information beyond sensitivity and specificity that we are likely going to be able to derive out of these PSMA PET scans. But there are real sort of repeatability issues that are kind of buried in some of these advanced imaging features that we definitely have not as a field figured out yet. I'd like to thank all the folks that have obviously helped generate some of the data that you've seen. And with that, I will pass it on to the next person. Thank you.
Thank you very much. Okay, our next speaker is going to be Dr. Rob Reiter. He's going to talk about MRI and biomarkers for evaluation.
All right, thanks very much. So we're going to change topics a little bit, kind of away from PSMA just for this talk, and we're going to talk about basically the integration of MRI and the various many biomarkers that are have been developed over the last 10 years or so in prostate cancer diagnosis and management. All right, so the indications for biomarkers in prostate cancer, there are obviously a number. One is for screening and diagnosis. The second is for staging of disease. The third is really for risk stratification, particularly decisions about treating a patient actively or aggressively, or placing a patient on active surveillance, and also in men on active surveillance, whether to essentially change management to active management versus continued active surveillance. And then, of course, in terms of treatment selection, focal versus surgery versus radiation, short-term or long-term androgen deprivation therapy. For the purposes of the fact that we only have about 20 minutes, I'm really going to just focus on the initial diagnosis, kind of how to integrate biomarkers and MRI imaging, and on risk stratification, that is the decision for or against active surveillance in a newly diagnosed patient. So I'll start by the first, which is in the setting of diagnosis. So right now, the tools we have, we've got MRI, which of course has become probably the most popular kind of diagnostic test and guideline-approved diagnostic test for initial diagnosis of prostate cancer. But we also have a plethora of both urine and blood biomarkers. These are just some of the ones that are listed. I'm not going to really compare any of them. I'll treat them as a group, but ExoDX, 4K, SelectMDx, and a number of others that have been introduced more recently into the field. So the big question in this area is how do we integrate these different tests, both diagnostic imaging and also urine and blood biomarkers to optimize diagnosis? And I think we would probably all agree that the desirable pathway would be we want to identify a high proportion of men with quote-unquote clinically significant prostate cancer. That itself can be debated, Gleason grade 2 or higher for the purpose of this talk. We want to minimize the number of men diagnosed with grade 1 cancer. That's certainly a goal of screening nowadays. We want it to be convenient and easy for the patient. We want to minimize the number of biopsies that are required, thereby reducing side effects related to the diagnostic pathway. We want to minimize anxiety, and we want it to be inexpensive. So we all know that this is the precision trial from a number of years ago from the UK, which basically demonstrated that if you compared MRI as an initial diagnostic step and biopsy only on patients who had a PIRAD 3 through 5 lesion versus systematic biopsy in everybody, that the MRI group, number one, there was a higher diagnostic yield in terms of clinical detection rate. And secondly, the MRI group required fewer biopsies were required to achieve essentially a better result, and fewer grade 1 cancers were identified. So this really has become the standard of care, I would say, over the last decade for initial diagnosis and biopsy guidance and diagnosis of prostate cancer. But at the same time, we know that MRI, while very, very good, very sensitive, is not perfect. This is a study from our group in 2019 where we looked for the diagnosis based on MRI of individual lesions. And if you look at individual lesions, given the multifocality of prostate cancer, what we found is the sensitivity of MRI for diagnosis of like grade 2 prostate cancer is really 60 to 70%. Even for grade 4 and 5 cancer, it was probably 80% or so. So not perfect. So the question is, can we do better by integrating some of the newer markers that we have? So this is just one of the many biomarkers, SelectMDx. I think there are similar data for many of these that basically demonstrate that these tend to have very high area under the curve and a very high negative predictive value with varying cutoffs. In the case of SelectMDx, if a threshold of 12.5%, higher than 12.5%, gave you a very high negative predictive value of 95%. So could you use this? The question is, can you use a biomarker as the initial selection tool for then obtaining an MRI and a biopsy, or should we start with MRI? This is just to show that MRI and many of these biomarkers may actually overlap in terms of what they're measuring. There's pretty good correlation between the 4K, ExoDX, and actually a number of other tests, and the PIRAD score in MRI, suggesting that these biomarkers and MRI may be measuring to some extent the same thing in terms of the potential aggressiveness of a newly diagnosed prostate cancer. So this is an interesting paper that was written by Andrew Vickers at Memorial and a number of others, just basically asking the question, what are the various strategies that we could use? Starting with a biomarker, and if it's positive, then getting an MRI if the MRI is positive, then doing a biopsy if it's negative, not doing it. Or starting with MRI first, and if the MRI is positive, biopsying. If it's negative, then biopsying only if a biomarker was positive. So there are a number of different potential strategies that they laid out that one could consider. And this was a really good paper from the group at UCSF, actually testing many of these different algorithms in a retrospective manner. And although it's too small for me to see from here, algorithm 2 was really starting with, in this case, the 4K score, and basically saying if it's less than a threshold value of 7.5, that no further testing is necessary. If it's greater than 20, perhaps you get an MRI and you do a biopsy regardless of whether the MRI was positive or negative because you had a high prognostic potential of having prostate cancer. And if it was intermediate, get an MRI. If it's negative, just monitor. If it's positive, go ahead with a biopsy. And the flip side, algorithm 6 is starting with an MRI. If it's positive, doing a targeted biopsy. If it's negative, not doing so. And what they actually were able to demonstrate, again, this is retrospective, not prospective data, suggested that actually starting off with a biomarker like 4K may actually reduce the number of MRIs, reduce the number of biopsies needed, and not lose much in terms of detection rate for clinically significant prostate cancer. So I thought that was very intriguing, and we actually tried to do a prospective study, and I think there have been a couple of others that are ongoing to really ask what is the best strategy that we should be using. But I think this suffices to point out that you can integrate the use of MRI and biomarkers in various ways to probably optimize the diagnosis of clinically significant prostate cancer. And so I'll complete that. But, you know, right now we don't have the answer about what's the best algorithm. I think this is an area that's really ripe for further investigation so that we can really do the best job for our patients. But I think it's intriguing how we can integrate these. So I'll move on now to integrating imaging and biomarkers for treatment decisions, primarily the decision of whether to operate, radiate, or place a patient on active surveillance. Here we've got a different set of biomarkers. Obviously, we've got our clinical pathologic models, Capra scores, D'Amico scores, PSA density, which I'll raise a few times. We can never forget how valuable PSA density is. In terms of tissue-based biomarkers, we've got Decipher, GPS, Polaris. The new kid on the block is Artera AI, which is a multimodal artificial intelligence. Basically, it's using prostate histology, just an H&E stain, to derive prognostic information without the use of any other biological measurements. MRI really is, it's not just a staging tool and a diagnostic tool, but it is itself a biomarker. And PSMA PET, which I won't talk about now, but actually also has a lot of information in terms of disease aggressiveness versus disease indolence. That can be all integrated together. Just some NCCN guidelines. We know our clinical pathologic tools. I won't go into those much more, but it's important to recognize that these are still really the baseline for guiding our clinical decision making. But I think what biomarkers and imaging are showing us is that for any given NCCN risk category, there's actually a spectrum of disease, great heterogeneity within disease that we're trying to understand. So I think there's been a lot of interest. One of the talks this morning is talking about, grade 2 cancers. They are not all created the same. Many may be quite indolent, can be treated like grade 1 cancer. So that's another area very continually ripe for further investigation in terms of identifying patients perhaps with grade 2 cancer who do not need any treatment and can be safely placed on active surveillance. Now, in terms of biomarkers, this is the most recent NCCN guidelines. Again, there are a number of different tissue-based biomarkers looking at gene expression, the Polaris score, Decipher, and GPS, AI pathology I mentioned, germline genetics I won't talk about, but also may play a role. But the two that have been really kind of risen to the kind of the top of the pile in terms of recommendations based on level of evidence are Decipher and Artera AI. So I'll talk about those today and how to integrate these with MRI. Again, Cannot forget PSA density. PSA density itself is really a great prognostic tool. PSA density is greater than the threshold of 0.15. That if you have a patient, for instance, who has a negative MRI, if a PSA density is greater than 0.15, about 20% of those men will have prostate cancer, significant prostate cancer, less than 0.15, probably less than 5%. So it itself is an important biomarker to remember. This is an unpublished study from Lenny Marks, one of my colleagues at UCLA, in our active surveillance trial. And he looked at basically PSA density, MRI PI-RADS score in particular in patients on active surveillance. What they showed, and hopefully will be published soon, is that a PSA density greater than 0.15 that's persistent across time is an adverse indicator of the presence of more aggressive disease. A PSA density that goes from less than 0.15 to greater than 0.15, also prognostic for worsening disease or stage migration, as well as an increase in PI-RADS score over time. The flip side of that is what's favorable in patients on active surveillance. Number one is a negative MRI that remains a negative MRI. That's a very strong, negative prognostic tool. Negative predictive value, sorry. If a patient goes from a positive MRI, like a PI-RAD-3, to a negative MRI, that also is favorable in terms of a patient able to stay on surveillance, and even a decrease in PSA density from greater than 0.15 to less than 0.15 in this study at UCLA. So what is Decipher? I think most people in this room know. It's been around for a number of years. But again, the purpose of these tissue-based biomarkers, genomics tests, is really to stratify risk for any given NCCN risk criteria. So you can see among patients who have NCCN low risk, the vast majority have low Decipher scores consistent with the NCCN low risk, but about 14% of men in NCCN low risk actually have higher risk disease based on Decipher. And the same is true for even high risk. Most men have a high Decipher score, but there is a subset of patients even with very high risk disease by NCCN risk criteria who actually, at least biologically, may have less aggressive tumors. So the idea is that we can stratify risk in patients by NCCN risk criteria. And this is also in NCCN guidelines, basically that you can then integrate using clinical pathologic criteria and a Decipher score, genomic risk criteria. You can integrate them to actually come up with kind of a clinico-genomic risk group. So for instance, patient who has very low risk disease by NCCN risk, but has high Decipher score, that patient then can be categorized perhaps as intermediate risk. So again, just combining these two without the use of any imaging data whatsoever. And indeed, Decipher can identify patients who have more aggressive disease in those who are candidates for active surveillance. Patients who had a high risk Decipher score had a threefold higher rate of harboring adverse disease. But it's important to note that not all patients with a Decipher high risk have adverse pathologic features. So again, these things need to be taken into consideration. None of them is perfect. So what about multimodal artificial intelligence? Again, as I said, this is a more recent development. Basically, what the group led by Felix Feng did is to use clinical histologic sections from patients in a number of different prospective radiation therapy trials, and then use machine learning to identify features, many of which are still unknown, features that would be both predictive and prognostic for outcomes in patients on those clinical trials. And in particular, as a predictive tool, this was used to determine whether a patient would benefit from short-term ADT versus long-term ADT in patients who have had very high-risk disease. But it's also been shown in the case of patients with newly diagnosed prostate cancer to be prognostic for progression over time. And again, this also stratifies risk in each different NCCN risk group. So again, here too, you can see for men who have a high NCCN risk group, not all of those patients have a high Artera AI score. Many of them, a very small number, may actually have low risk. And among patients who have lower or intermediate risk cancer, there's a subset who actually carry high Artera AI risk. So again, very similar to what's being done with genomic signatures, is to really try to integrate all of this information together. And this basically shows, this is a paper from Ashley Ross at Northwestern, published just this past year, showing the potential utility of prognostic utility of this model for prediction of outcomes in men with newly diagnosed prostate cancer in terms of risk of metastasis and risk of death from prostate cancer, suggesting that the subset that have very high Artera AI risk may actually harbor very aggressive disease. But of course, not only are these genomic and tissue-based biomarkers of utility, MRI itself is a biomarker. As most of us know, men who have a PIRAD-5 score tend to have much higher likelihood of clinically significant prostate cancer versus PIRAD-3. We published a number of years ago, Jim Hu, from the early days of MRI, that if you had a PIRAD-5 score, that you were more likely to harbor adverse pathology and not be a candidate for active surveillance. We also know from another paper from UCLA by Adam Kinnaird a number of years ago in our active surveillance series, that if you have a detectable lesion, PIRAD 3 through 5 on an MRI at the time of diagnosis, you're more likely to progress over time on an active surveillance protocol or not be a candidate for active surveillance after an initial confirmatory biopsy, again suggesting that MRI information itself is carrying clinically important and biologically important information. It's another study from our group, Isaac Fayano, one of our former fellows, showing that among patients who had a biopsy Gleason score of 3+4, looked similar histologically, but that the PIRAD score predicted for biochemical recurrence among patients who underwent surgery, with patients who have a PIRAD-5 lesion have about a 50% likelihood of progression over time. Again, suggesting that the PIRAD score carries biological information that may be important for prognosis. And I thought this was a really interesting paper by Sunderson in Journal of Urologic Oncology. I don't have time to go through it, but basically this is something we see often enough. Somebody who's got a PIRAD-5 lesion, but a grade 1 cancer, what happens to those? We know PIRAD-5 is associated with worse disease, but hard to get away from grade 1 being found on a targeted biopsy. And this shows that in at least half of instances, patients who started out like this actually did harbor more aggressive disease when monitored on active surveillance over time, suggesting that we need to be very careful about patients who have PIRAD-5 lesions but grade 1 on biopsy. I'm not saying they should all be treated by any means, but these are discordant features that need to be monitored carefully. So how about integrating the tissue-based biomarkers with MRI? This is a paper looking at Decipher. I think the far right is what's important. Basically, that shows that they probably actually work together. They're probably synergistic in some ways, that Decipher actually can help stratify risk by PIRAD scores. So patients who have PIRAD-3 lesions tend to have lower Decipher scores. Patients who have PIRAD-5 lesions tend to have higher Decipher scores. So if you've got a PIRAD-5 lesion and the Decipher score is high, most likely that patient should be treated and probably harbors more aggressive disease versus a patient who's got a PIRAD-3 lesion on MRI and has got a low Decipher score. We published a paper that showed very similar integration of the GPS tissue-based biomarker with MRI, showing that GPS in this instance actually provided independent prognostic information beyond the PIRAD score in patients with Gleason 7 cancers, grade 2 cancers. And that's this paper here, published in 2019 in Journal of Urology. So finally, I think a few more slides, really kind of to bring that home, that the PIRAD score itself and MRIs themselves provide biological information that may be of critical importance. This was a study we published now a few years ago think it was in European Urology, where we basically did RNA sequencing and DNA sequencing on a group of patients who all had histologically the same size cancers. They were the same, histologically they were the same size. They looked similarly histologically in terms of grade 2. But half of them were not, they were negative by MRI and half were positive by MRI. So we wanted to see whether or not we could use genetics or gene expression to really understand why some patients had tumors that were visible versus invisible. And basically the summary of that paper is here. Nimbosis is a term to describe multiple adverse features associated with progression. And we found that there were genes such as SHLAP1, which is known to be a marker of aggressive prostate cancer, that were much higher in patients who had MRI visible disease. Again, these are all grade 2 cancers histologically. The percent of genome alterations, that is increased genome changes in genome alterations, chromosomal stability, was higher in patients who had MRI visible disease. And things that histologically we know are associated with worse prognosis, like cribriform and intraductal cancer, were really enriched in patients who had MRI visible disease. And you could actually put all this together and come up with a prognostic tool with a very high AUC associated with MRI visibility. And this, again, just suggests that there's biology underlying MRI visibility. It tends to be consistent and concordant with the information that we glean from tests like Decipher and most likely ARTER-AI as well. And so MRI visibility itself, it can identify patients who may progress on active surveillance, but also those who may need treatment. Not only did we were able to show this genomically, but we also did some proteomics that showed something similar. There was clear protein signatures that were associated with tumor visibility on MRI. And I think this work that we did has been replicated in a number of other studies demonstrating radiomic studies showing the association of MRI visibility with different genomic features. And this is a signature we came up with, proteomic signature associated with visibility. So I'll end there. A couple of summary slides. So number one, there's an increasing number of clinical, pathologic, genomic, and imaging biomarkers that can aid in clinical decision-making. They may be useful for who to biopsy and who to treat versus surveil. MRI and both blood and urine biomarkers can be used for diagnostic decisions. Biomarkers can be used to identify those who need MRI and those who need biopsy, but the optimal sequencing really remains unclear, and we need more prospective trials to really figure out what's the best way. I haven't really talked about comparison of the different biomarkers. There's not been a lot of work comparing individual biomarkers to see how well they correlate with each other. MRI and tissue biomarkers provide both biological and clinical information and are often concordant. A high PI-RAD generally associated with clinical significance. A negative MRI is a high negative predictive value, and cancers associated with a negative MRI may be biologically of lesser significance, that is invisible, quote unquote, invisible tumors. Tissue biomarkers and tissue-based AI may provide independent information, particularly for intermediate risk tumors. But I think it's important to caution that oftentimes we see discordance between histology, tissue biomarkers, and MRI. For instance, I see all the time patients who have grade 1 on a targeted biopsy, a negative MRI, so I think they're low risk, but then have a high Decipher score. What do we do with those guys? Or somebody who's got a PI-RAD 5 lesion, but a low Decipher score. So I think there's much more that we need to learn to really integrate these different tools that we have, but I think we are certainly much further along than we were a few years ago. So I'll end right there. Thanks for your attention.
So thank you. I think our next speaker is Dr. Yu. We will have time for questions at the end. We'll just group them all at once. And we also have some case studies, which we're going to go through. Okay?
Great. Well, thanks for having me here today. I get to talk about practical applications of use, PET, MRI, et cetera. And I'm just going to disclose right up front that Dr. Rowe and I have quite a bit of slides in common, especially in the early part of my talk, but I'm going to kind of blast through those and maybe try to bring out some points that Dr. Rowe didn't talk about so much and try to not have it be repetitive for you all. So here's my disclosures. And the discussion topics, we'll talk about PSMA PET for staging, PSMA PET for biochemical recurrence, and then PSMA PET for identification, an ideal selection of patients for PSMA-targeted therapies like radioligand therapies, for instance, lutetium, PSMA 617, and then future uses, potential to monitor disease progression, monitor disease response, and then also a little bit with integrating MRI with PSMA PET. So what are the improved indications for PSMA PET? Well, suspected METs in candidates for initial definitive therapy, suspected recurrence based on elevated PSA levels. This is usually biochemical recurrence after you've had local definitive therapy. And then also selection of patients with metastatic prostate cancer who are candidates for lutetium PSMA-directed therapies like lutetium 617, for instance. Now, the approval is actually formally for gallium-68, but it's really broadly applied to all PSMA agents in clinical practice. And in general, they all provide higher sensitivity and specificity for detecting prostate cancer sites compared to nearly all other conventional imaging modalities. So just real quick initial staging, a little bit about the PRO-PSMA study here. This was a multi-center randomized controlled trials, high risk localized prostate cancer, 302 patients were randomized. And just in summary real quick is that the accuracy was 27% greater than that of conventional imaging. I remember when this data first came out, I was sitting next to Dan Lin and I said, 27%, does this make a difference to a surgeon? And he was like, heck yeah, this makes a difference to a surgeon and planning our surgical fields, et cetera. So I'm like, okay, well, that's important to know that it's something that affects treatment management here. Here's just a little bit more granular data looking at the specificity and sensitivity generally showing that it's better than conventional imaging, certainly in regards to sensitivity in this early disease state of detection here. And then you saw this slide here also as well. This is using PYL rather than gallium-68, but Dr. Rose showed this slide and mentioned about the fact that the sensitivity is more moderate, the specificity is very, very good. The one thing I will bring out in this study is that even though the sensitivity is in the 40-50% range, 98% of these patients that went on this study had completely negative conventional imaging. So again, it's not really taking all comers, some of which you, if you squint, you find actually the METs on conventional imaging as well. So just to put that a little bit into perspective. I think the key thing is this is a complex diagram, but it shows what happens afterwards and how you change management. And in the PRO-PSMA study, first-line conventional imaging resulted in less frequent management changes, 15% versus 28%. 27% of those men who underwent second-line PSMA PET imaging, however, had management changes. But there's real-world data as well with PSMA PET, and it's very clear that there are change in management plans. I think the important thing to show that this analysis shows that up to 60% of patients have change in management. And if you have PSMA PET detected local disease, it's more likely to be considered for local treatment. But if you have metastatic disease found by PSMA PET, you're more likely to change towards adding systemic therapies and maybe going towards systemic therapy like androgen deprivation therapy with radiation, et cetera. So now I want to go on a little bit with opportunities to melding PSMA PET and MRI. We're doing a lot of PSMA PET MRIs at our center. Most studies show improved staging when you combine both because PSMA uptake can be heterogeneous. MRI might not always detect all the cancer areas, and PET MRI can improve co-localization and detection of prostate cancer extent. So here's just a little bit of a diagram from a patient of ours. You can see how PSMA PET can complement MRI for staging there, the tumor there abutting against the capsule. But the thing to point out is that not all tumors have PSMA PET uptake, and that's where sometimes MRI can be especially helpful, is if your PSMA PET is not very high uptaking as well. You can see after the radical prostatectomy, the specimen and the location of the tumor that you see there on MRI imaging. Now, quickly moving on to biochemical recurrence. This is with gallium-68 PSMA 11 imaging, and you can see here how at low levels of PSA, you can even start to detect at less than 0.5. You see the detection rates are a little bit less than 40%. but certainly much higher as your PSA level goes up. And again, Dr. Rowe showed this slide here. This is using PYL imaging, and again, looks reasonably similar there, where you're getting higher and higher detection rates as you go up by PSA. Dr. Rowe showed this as well, the Oriole trial, but here's also the OS trial, which the OS trial used choline. So PET, not PSMA PET, but choline PET. This is before we had PSMA PET FDA approved, to find metastases for those with biochemical recurrence, and then to do oligometastatic directed therapy. The Oriole trial is listed here as well, but that was also they had used conventional imaging, and they ablated conventional imaging detected sites there in that study. And I think the important thing to show here from the OS study using choline PET, and I think the principles can go across to PSMA or flucyclovine or whatever you use there, is that if you have more sensitive imaging and you go in there and do MET-directed therapy with radiation, let's say SBRT, et cetera, what you effectively can do is you can do a little resetting of the time clock, drop the PSA, have a longer time to PSA recurrence again, and it does improve time ADT-free survival. So for patients who don't want to go on systemic therapies, you can knock that PSA down, reset things a bit, and then push the need for systemic therapies with androgen deprivation therapy down the road. Now, we need more definitive data. Are we prolonging survival? Are we prolonging radiographic progression-free survival? We don't know that yet, and that's why I like this study that Neha Vapawala is leading through ACKNOWLEDGEMENTS. We're running it through SWOG as well. It's really asking two questions for those that have relapsed after radical prostatectomy that are being considered for salvage radiation therapy. It's asking the question is, A, the systemic therapy, intensified systemic therapy by adding apalutamide to androgen deprivation therapy, the 6 months of ADT they give with radiation, does that lead to benefit? And then B, for those that have oligometastatic disease found on imaging studies, on PSMA PET, they're treated either with 6 months of ADT plus apalutamide or 6 months of ADT plus apalutamide and MET-directed therapy. Does that MET-directed therapy actually improve progression-free survival? So this trial is actively accruing at this point in time. There's another trial that is accruing a similar disease state for salvage radiation therapy. This is asking a different question, because everyone in the Promethean trial here will have PET-positive imaging by METs, and then they will be randomized to either oligomet-directed therapy or oligomet-directed therapy with 6 months of Relugulix. And the question here is not, does the oligomet-directed therapy lead to longer radiographic progression-free survival? The question here is, do you need the systemic therapy when you do oligomet-directed therapy? All right, and here's a little bit of propaganda. So I designed this study here at our center, and we're just doing it at our center and University of Pittsburgh, where a fellow that I trained went there, Risa Wong. And this is taking patients who have relapsed after prostatectomy and then developed, again, relapse after salvage radiation therapy. There isn't a lot going on in this disease state. And I'll just say we're doing PSMA PET. If we don't find anything, we're following the patients out with every 3 months PSA. And then when they hit certain thresholds, PSA of 2, PSA of 5, we're re-imaging them again. The group that we're really looking for is one with, let's say, 3 radiation regions, radiation fields. So if you find that, then what we're doing is we're giving 6 months of ADT and abiraterone, and then we're doing either surgical resection, if there's lymph nodes that can be resected, or radiation therapy. So it's really kind of dealer's choice there. But it gives an opportunity for a disease state that's thought to be like, well, you tried all the local therapy you could do already. This gives another shot at goal there. Now, what about therapy selection for patients with metastatic castration-resistant prostate cancer? I mean, this is really where medical oncologists are using it the most. So we're using PSMA PET to select for lutetium-177 PSMA treatment eligibility. It's FDA approved already. And again, as I mentioned, gallium-68 was FDA approved, but certainly you can use F-18 Pylarify, you can use Posluma, you can use any of those imaging studies there in this situation. But I want to go through the eligibility criteria in these advanced disease studies. So the VISION trial is what led to FDA approval of lutetium PSMA 617, and this required that you had PSMA uptake above liver intensity, which is about SUV7, in any lesion in any organ in any size. But you had to have no PSMA negative disease, defined as uptake less than liver intensity in any node that was greater than 2.5 centimeters, solid organ or bone lesion soft tissue component greater than 1 centimeter. FDG PET was not used. Now, therapy was a study also in this kind of post-ARPI, post-docetaxel disease state, and the patients were randomized to getting lutetium-617 or to getting cabazitaxel, but they had much more stringent eligibility criteria. They required at least one measurable lesion with a max SUV greater than 20, and all other measurable lesions had to have a max SUV greater than 10. So a high bar, not just liver uptake. And they did do FDG PET, and you couldn't have discordance. You couldn't have FDG PET positive, PSMA negative disease sites, because we think those patients do worse, and I'll show you some data there. So vision and therapy, they both show improved PFS compared to standard of care alone, or cabazitaxel. And standard of care in vision was essentially ARPI switch, and some used steroids, let's say like prednisone, but they both showed improved RPFS. With OS, we can use PSMA PET and generate some biomarker data. So here's some quartile data that shows if you look at the total body mean SUV, that you get better outcomes if you have higher PSMA PET uptake. None of this is surprising. This holds true in all of these studies, but it makes sense, and it's something that down the road we should think about really using, especially as we have more and more treatment options for our patients with metastatic prostate cancer. We need to start splitting hairs and deciding, well, this patient's better for this treatment, this patient's better for that treatment. Looking at actually just how much PSMA PET uptake is there can help us delineate that. And this looks at the outcomes in the therapy study based on whether the SUV mean PET uptake was greater than 10 or less than 10. And if you can see, if you have greater uptake, you're going to get better outcomes, better PSA declines, et cetera. Now, what about FDG PET? I just mentioned in therapy they did do FDG PET. And the thing about FDG PET is it's really just a poor prognostic marker. PSMA PET is a prognostic marker, but it also can be predictive for treatment with lutetium-617 PSMA. But FDG PET, that just kind of means you got bad disease there, whether that's, heading towards neuroendocrine disease or one of the prostate cancer variants like amphicrine or double negative. These are generally just poor prognostic tumors that don't do as well there. And then here's outcomes in the patients that actually, in the therapy study, there were a lot of patients that got PET image and were not eligible. So if you look at the outcomes, the prognosis, if the therapy eligible versus therapy ineligible patients, clearly the ineligible patients are those who have discordant disease on FDG and PSMA PET. Those patients do worse. Again, not surprising there, but got to show the data, right? So, and then outcomes in patients with or without PSMA and FDG, discordant disease, taking a specific focus on that. If you have discordance, again, you're apt to do worse there. Not surprising. So, the ideal patient for lutetium-177 PSMA 617 is those that have high expressing PSMA expressing tumors. That predicts a good response. If you have intermediate to low, or discordant disease, it's kind of more of an intermediate response. And if you have highly discordant disease or negative disease or really high FDG uptake, that's generally a poor response. So let's talk about response and progression, because this is the future. We're moving towards doing less and less CTs and bone scans and more PSMA PET imaging. Can we use it to get drugs FDA approved for systemic therapy? So there have been different groups that have proposed different frameworks. I'm not going to go through them all in great detail, but for looking at response and progression. Right now, in metastatic castration-resistant prostate cancer, we're generally looking at progression of disease because we don't have a good way to quantify bone met response, certainly not by bone scan. And even by PSMA PET, all these groups are very hesitant to use decrease in SUV as a response marker. So what they're really mostly looking at is, does everything go away? Does it go cold? Can we call that a complete response? Or are we seeing new lesions pop up? And so I'm going to focus a little bit on some of the different studies. This is the RECIP study, which is response assessment criteria tested in patients treated with lutetium-177 PSMA. It was a retrospective study 3 centers, and what they did here is they tried to do it like RECIST 1.1, which is increase in tumor size on CT scans by 20% would be progression, decrease by 30% would be response. And what they're using here is they're looking at this response and progression based on tumor volume percentage changes and also presence of new lesions. And so here's their development plan here. They had a CR, which meant absence of any PSMA uptake on PET. They had a PR, as I described, and progressive disease if you had appearance of new lesions, stable disease if you didn't fit quite in there. And this is really how they developed it. And here's the correlation with PSA response. So it did have some correlation. If you didn't have a PSA response, that generally correlated with RECIST PR. If you did, it correlated better. I'm sorry, it didn't correlate with RECIST PR. If you did have a response, it did correlate with RECIST PR. I said that opposite. All right, now Michael Hoffman's also done some work with the Prostate Cancer Working Group 4, and that's the group that I'm working with, mostly medical oncologists in that group. And in that, there's going to be a Working Group 4 paper that comes out with some guidelines for industry to help develop clinical trials. There's going to be a separate imaging paper. And the details in this preliminary manuscript or presentation that Michael Hoffman presented was from the Prince trial where they were looking at immunotherapy as well. But what he did is he wanted to incorporate CT with PSMA PET, and he wanted to define basically complete response as no PSMA positive lesions, progressive disease as 2 or more lesions, and then requiring confirmation. So similar to what we're doing with conventional imaging right now. And as you can see here, the outcomes there by whether you fit into progressive disease, by whether you had a response or not, did have correlation with radiographic progression-free survival. My only argument here in critique is that we do need to seriously think as a field, as we love seeing things change on PSMA PET, is usually things change on PSMA PET soon after seeing things change by PSA. PSA is a pretty cheap biomarker to use, and so I would love to see the PSA progression-free survival curves and just see where they look pretty similar, but just shifted a little bit over there. This is a little bit of our own data. I work closely with Delphine Chen and Amiri Irvani in our center, and I want to send some caution out there to say that changes on PSMA PET may not be the end-all, be-all. It may depend upon what treatments you're using. This is with chemotherapy. We've been doing PSMA PET before and after chemotherapy, and we actually find that the changes don't always correlate with PSA. The changes don't always correlate with what we're seeing with CT and bone scan. Here's somebody that we gave docetaxel to, and things looked a lot better on PSMA PET, so they might not be a great candidate for lutetium-617 down the road. The PSA went sky high, so just a little bit of caution as we try to establish new guidelines for use of PSMA PET for response and progression down the road. It's not a perfect world here. And then just a little bit of data how we might use PET is, here's an example of using, PET MR is a little bit example of using MR for detecting liver metastases. Here's the outside PSMA PET CT, outside FDG PET MR, or our PET, FDG PET MR that we did at our center. And then a small focus of FDG or PSMA uptake in a new small liver metastasis that you can see there on the conventional imaging there. But here's what happened on follow-up. So it's not always perfect here. You see PSMA PET, you see FDG PET at baseline. PSA was 143, and then cycle 1 spec, cycle 2 spec, maybe getting a little bit better there, but PSA is going up. And what you see with the anatomical imaging is that you do see an enlarging lesion on anatomical imaging. And here it does light up more on PSMA PET with the liver metastasis. This is after treatment with lutetium-617. So it's not a perfect world. We'll have some more perfect world cases as we move on to the case section of our presentations today. So in conclusion, PSMA PET detects greater extent of prostate cancer, more sensitive than previously appreciated, has a clear role in surgical planning. PSMA PET and MR provide complementary information that can provide complete staging information. PSMA PET may identify lesions for oligomet-directed therapy for biochemical recurrence. although the long-term efficacy is yet uncertain. We can really delay need for ADT, but we don't know that there's improved survival. PSMA PET is what we use for selecting lutetium-617 for radioligand therapy, and then for use of disease progression and response, that still requires validation. So thank you very much. I want to acknowledge Delphine and Amir, who shared some slides and nice images with me.
Okay, we're going to go through a few cases, which I think will be interesting. But before, Dr. Rowe, you want to just briefly describe, as I was thinking about the talks, we throw around SUV an awful lot. Do you want to just explain to the group, a lot of urologists in the room that don't spend a lot of time talking about and thinking about SUVs?
Yeah, absolutely. Hopefully everyone can hear me from here. So SUV, standardized uptake value, is essentially a unitless abstraction of the radioactivity concentration in a given volume. So for the most part, we use a maximum SUV, which is the most repeatable sort of way we have to describe uptake in a lesion. But it's also a single voxel measurement, so it tends to be very, very dependent on noise. So people also will describe use of things like mean standardized uptake values or peak standardized uptake values as sort of ways to try to get around the noise inherent to maximum SUV. But fundamentally, the way to think about it, I think, is just it's a radioactivity concentration.
Usually you're comparing it to something. When you're assigning something as positive or not, it's a comparison, isn't it?
So it can be, although we struggle with, we do struggle with sort of absolutely what SUVs may mean, and this is even outside of PSMA PET as you look at FDG PET and other things. There's certainly a meaningfulness over time, and there are sort of defined limits of repeatability that are probably within about 20 or 30% of, say, an SUV max across serial images that may mean you have sort of objective progression or response. But yeah, in terms of absolute values with SUVs, it's often hard for us to define what those mean. So, for instance, when I started as a resident, I was told unequivocally by a couple of fairly senior attendings that if you had a lung nodule that had an SUV max above 2.5, that was cancer, and below 2.5, it wasn't. And it turns out that's total bunk, and no one uses that anymore. So yeah, exactly what the sort of absolute SUVs mean is definitely subject to debate.
A little bit of an art. We have some case studies to go through, but why don't you ask your question, and then we'll have other people come up and ask after we do the case studies. I think you need, can we turn the microphone on or turn it up a little bit?
Might need to be turned on.
Oh,
There you go.
so yeah, we have a session tomorrow on retreatment protocol using actinium. So while we're going through the data, I noticed that we did calculations of PSMA SUV mean and SUV max. So when is mean more significant than max? That's my question.
Oh, so, a great question. And I think both have been independently validated as potential biomarkers in at least the use of lutetium, PSMA 617. I would probably lean towards sort of a mean or total body mean SUV as being a more robust indicator of a biomarker for either predictive or prognostic biomarker in terms of response. But that's a little bit shooting from the hip. I don't have any real data necessarily to point to, but
in our analysis, we found that PFS is related to both the mean and the max.
Yeah, no, and they are going to be very tightly associated for the most part. It's just that max again is going to be ultimately a single voxel measurement, and so the repeatability of that's going to be much lower than the repeatability of potentially a mean SUV. But there are also lots of problems with repeatability in terms of how you're segmenting lesions and things like that. So lot of unknown, I think a lot of unknowns and trying to figure out which of those is going to be the better metric.
I'll just add that you bring up a really good point. I mean, when you get a typical radiology nuke med report, they're not giving you total body mean SUV.
Definitely.
So, I'm fortunate. I just send an epic message to Amir, and an hour and a half later, he sends it to me. But not everybody has that luxury.
So why don't we go through some of the cases that we presented, and then we'll have plenty of time for questions. Promise, okay? So this patient is a 64-year-old male. His PSA is 1.99 in 2015, and then he doesn't get it checked again for a little while, right? It's probably a mistake. PSA goes up to 5.77 in August of 2021. He's a pretty healthy guy, no family history of prostate cancer. I'll put Rob on the spot first, since he spends more time managing this than anybody else up here. Rob, what would you do next?
So, I mean, this brings up a little bit, I guess, the first part of my talk. So I would either start with a biomarker or I'd start with an MRI. So, I thought about what do I do in real life? I'd say generally somebody I've got a very high suspicion of having prostate cancer, I just go right to an MRI. If I have a lower suspicion, I'll get a biomarker. So obviously this PSA change, even though it's occurred over 6 years, looks pretty significant, so I'd get an MRI.
And so that's what I usually do. I kind of kick myself sometimes. I feel like if you're just looking at the data, probably the biomarker followed by the MRI probably makes more sense. I say probably because I'm not sure of that. But usually I'll reserve the biomarker for when it's discordant. One of the things I always do is repeat a PSA on somebody who hasn't had one in a long time. And I try and wait a little while. I don't do it like a week later. I mean, I want to make sure that it's not an infection or that, and I tell them to abstain from sex. There's other stuff out there that people have in the literature, like bike riding. I find that really doesn't have a huge impact, but I still tell patients to do it just to make sure. So he gets an MRI because, the two of us think very similarly. And he's got a PIRAD 3 lesion at the right with bulging of the prostatic capsule. So again, I'm going to put Rob on the spot. Rob, what do you think about that? That's a little different, isn't it?
Yeah, we'd probably biopsy him.
Yeah. So
and that brings up, would you use PSMA ever in this context? And occasionally we will, because there's no doubt that I think we published a paper, about 10% of cases, the addition of PSMA will, provide some assistance in terms of either targeting or diagnosis.
I don't have it in here, but I think PSA density is an incredibly important biomarker. And if someone has a PIRADS 3 lesion that's got a very low PSA density, I usually feel pretty good about it. If it's a high PSA density, I'm really worried about it. I didn't include it. Evan, Stephen, you have anything to add to that? No?
Yeah, no, I would echo the idea that, I think PSMA PET in the U.S. is hard to get reimbursed in this context because this patient doesn't have prostate cancer yet. So if I'm an insurer, I'm going to say, well, you don't have prostate cancer, I'm not going to pay for your PSMA PET. But there is relatively compelling data from Australia in particular that PSMA may have something to add here. But
that's interesting, thoughtful. It's going to be very expensive. We have to get MRIs and PSMA PETs on everybody before we even go to a biopsy. So he gets so the role for other biomarkers, we just talked about that. So he gets a biopsy in January of that year. It's at an outside hospital, not at ours, and his Gleason score 9. And on re-review, they downgraded it to 4+3, but high volume. So again, I'll put either Evan or Rob on the spot. You have everything re-reviewed at your place, right?
I'll just add real quick. Now you can get a PSMA PET.
Right. We're hoping. I was trying to talk a little bit about that, but yes, do you ever get a CT scan or a bone scanning? Is there any use for a CT scan or a bone scan in this situation anymore?
Yeah, I get a diagnostic CT when I get the PET scan. So.
Okay. I'm going to put him a little bit on the spot. What about Chris Sweeney's data and the whole idea of high volume versus low volume metastatic disease determining whether or not you're going to treat the patient? Do you have to get a bone scan in order to do that, or do you feel like you can judge that from a PSMA PET alone?
I'm kind of old school. I still like bone scans there, but if you're getting a PSMA PET and you have a lot of things that light up on PSMA PET, then I could get a bone scan after that. If I get a PSMA PET and there's no signs of any metastatic disease, then I don't feel like I need to. or let's say there's 1 or 2 nodes that light up, or even 1 or 2 bone lesions, that's going to be low volume disease. I already know it. But if you have 15 things light up on PSMA PET, I might get a bone scan to help me decide whether it's high or low volume disease.
So the issue here is the data from Chartered really defined high volume versus low volume disease on the basis of bone scan data. And the problem that you have is the criteria for which treatment you should go with. Low volume metastatic disease, do you go with radiation potentially in a patient like this because of trials like ORADS, or it's higher volume, you have to get more aggressive like the PEACE trial, really becomes a dilemma for the for the medical oncologist. I mean, you agree with that, Evan, right?
Yep.
Okay, so I think we sort of answered this, PET for grade group 3. I sort of think about high volume disease as sort of deserving it, both of you as well? Okay. So, volume, how about cribiforming? What if it's low volume cribiforming cancer? Does that make you think you should get a, Stephen, you want to answer this? What do you think?
Well, as a nuclear medicine physician, I'm probably not qualified to answer that, but I think you're well within the guidelines to get a PET for a patient with grade group 3 disease, and I guess the question I would have for everybody up here or in the audience is, does that get to the inflection point of where you have more false positives than you do true positives? And the NCCN and other folks didn't think so. So I would say that this patient should get a PSMA PET, but I could also, I guess I'd also say that most of the pivotal clinical trials that have been done are in grade group 4 and higher patients. So I think it is something we should probably debate more.
Rob, you look like you want to add something.
I mean, in the prospective study leading to gallium PSMA being approved in the U.S., most patients, they were grade 3 and higher, and that's what is, as you said, in the guidelines. So generally, especially given this high volume, I would absolutely get a PET CT on him for sure. Okay,
he decided on surgery, but I got a PET ahead of time. And you can see right here is a lymph node anterior to the prostate. So we struggled with what to do, and we ended up operating on him because we thought that's within our field. We'll go ahead and we'll take it out. I'm not sure. I mean, it was very interesting. I think one of you presented data which showed that the patients that are PET positive do worse and PET negative do better, irrespective of, but I was like, I can get that. So, and I did get it, right? But his PSA did not become undetectable. So I guess this is more for Dr. Yu. Evan, what would you do next?
Yeah, I don't like it when PSA PET doesn't go undetectable. Yeah. So this is somebody who disease, and at this point in time he's going to heal up from surgery, and we're going to talk to him about whether we think there's a role here for salvage radiation, and I would give some ADT with the salvage radiation because there's probably some systemic disease. So I would look into that, recognizing that probably poor prognosis for being cured by salvage radiation and ADT.
What ADT would you give?
Yeah, well, it would depend upon what I might get another PSMA PET, and see. I just want to see, while he's healing up, because I'm assuming this was done like 6 weeks after surgery. I'm not going to want to give him ADT and radiate him right away because you don't want him to be a little more continent. And then, I would check and recheck the PSA and see what those PSA kinetics are, and that might drive me to get another PSMA PET, because what we talk about a lot is what the absolute PSA value is, but what may matter even more is PSA doubling time. There's not a lot of literature out there for PSA doubling time, but I see lots of patients with high PSAs and slow doubling times, and their net PETs are negative, and vice versa, low PSAs and short doubling times.
It always makes me feel good when somebody I don't actually work with, has the same plan. So our plan was to give radiation, but we repeated the imaging at 3 months. And there are multiple iliac and pelvic nodes that are positive, including a sclerotic inferior ramus node, which I highlighted here, which hopefully you can see from the back of the room. I think that's also something that is not part of this talk, but we can pull all these up on our computers, and I'm sort of looking at it and squinting, and I can't see it. And then you go downstairs and you look at it on the real system, and the stuff is so much easier to see. So don't be fooled by what your desktop computer can show. So now, has your plan changed, Evan?
Well, yeah, I think what I'm going to do here is, you could treat him like he has metastatic disease, but you could also be more aggressive, and you could irradiate him with ADT, and I would add abiraterone because he's got positive nodes, and probably a positive bone met there, it looks like, as well. So this is somebody, what I would do is, again, there's no guidelines to manage this, but he probably, by conventional imaging, does not have potentially any detectable metastatic disease or has very minimal nodes. So to put him on lifelong ADT and, let's say, abiraterone or enzalutamide or anything seems like a little overkill. What I would do is I'd give him a couple years of androgen deprivation therapy with abiraterone, ask the radiation oncologist if they can irradiate everything, then stop and kind of see what happens. We can always reinstitute the systemic therapy again later if he relapses.
There you go.
Raise
Sure.
one point. Apropos of what he just said.
He hasn't seen these cases, so we're in agreement. Violent
Apropos of what he just said, we just published a paper looking at patients who would have biochemical recurrence and short PSA doubling time according to the EMBARK trial.
Yeah.
There was no PSMA imaging, and 80% of those patients had PSMA positive, disease. So, extrapolating from what we knew to what we know is difficult.
So treated with radiation and abiraterone for 2 years with RT to the iliac met. 3 years out, his testosterone's normal, his PSA is undetectable. Do I think he's going to be like this for the rest of his life? Absolutely not. I think this is sort of a drug holiday is the way that I look at it.
Not bad for not having seen the case, huh?
I know. Okay, here's another case. We're going to get to some metastatic disease shortly. So this is a patient, a 57-year-old male. PSA is 6.4. And no prior PSA, no significant medical problems, no family history, right? Next steps. So again, Rob, what would you do?
I mean, you could do it. You could go either way. I'd probably get an MRI on him. He's 57. That's pretty high PSA.
So you got a prostate MRI. PIRADS 4 lesions bilateral, possible SV invasion. Biopsy in November showed bilateral disease with a Gleason score 9. Again, high volume. One core is suspicious for seminal vesicle invasion, and his conventional imaging is negative. For the sake of time, we'll just get to the point, which is, you end up getting a PET. Okay, so here is these positive lymph node. There's one on the other side as well. So my question for you is, does this alter your management, Rob? You see a lot of patients like this. I know I see a lot of patients like this. Do you operate? Do you not operate? Do you send them for radiation? What do you do?
Me?
Yeah. You're the only one here who's... well, we have Evan operate on him or Stephen, but I don't think that'd be quite as good.
I offer these guys the 3 options. I mean, I say, I think largely still the standard of care is probably radiation with 2 years of ADT plus an ARPI. If I have a protocol like Proteus, I offer them that. This is a classic patient for that scenario. Or if they do not want that but want surgery, luckily I'm able to do radio-guided surgery, PSMA technetium, and use a probe like a Geiger counter essentially. So we would operate using that. Whether that leads to superior results, definitely we get the nodes 95% of the time that we find on scan. Doesn't mean there are not additional nodes, as you know. So
I'm just gonna say I can't find these nodes. I mean, so you're gonna see I operate on some of them. And you can't find them if you're just digging around. So UCLA, UCSF, and his Mayo Clinic have developed these wands to find the...
I don't know what other sites in the U.S., but a lot of this is being done in Europe. We've been doing it. We've done 30 patients so far with radio guidance. But we do find these nodes now. Historically, I wouldn't have, because that's either a perirectal or a deep internal iliac node.
Yeah. Okay, so very concerned about rectal toxicity from the radiation, but in the end, we decided to give radiation with Abby for 2 years. He's still castrated and his PSA is undetectable. So, Evan, you want to take us through this case?
All right. This 73-year-old gentleman in May of 2014 diagnosed with prostate cancer. PSA was 260. Gleason score was 8. Bone scan showed multiple bone mets. This was way back in 2014. CT scan showed retroperitoneal lymphadenopathy. Got treated with old school Lupron and bicalutamide. And then in June of 2017, had developed MCRPC, so got started on abiraterone and prednisone, added on there. And then eventually PSA progressed again and then went to enzalutamide. So multiple different hormonal agents. By June of 2018, got 10 cycles of docetaxel as his disease was had PSA rises, but developed some peripheral neuropathy. It was problematic, so he went on a break, even though he had an outstanding response. And then by July of 2019, his disease was progressing, so he went on cabazitaxel every 3 weeks for 3 years. So this is a an unusual patient that he kind of responds to everything. Late 2022, early 2023, his PSA progression was noted, and by February 2023, had worsening performance status, significant fatigue, poor appetite, multiple systemic constitutional symptoms. So other active medical issues was notable for a history of heart failure and atrial fibrillation, was on digoxin, metoprolol, and blood thinners as well. So it was considered for lutetium PSMA 617, but it wasn't available at that time because there was a supply shortage. You can see this is a real patient here. So instead, we gave him in February 2023, radium was started, received 3 cycles, however, suffered PSA and radiographic progression. And then in May 2023 was re-referred for lutetium PSMA 617, and we were able to access it.
Can I ask you a quick question? So it's hard for me to read because it's small. Hopefully it projects better up there. But you kept on talking about FDG PET in all of your discussions. Yeah, I didn't see an FDG PET there. Maybe I just missed it.
Yeah, we didn't do an FDG PET. What we try to do is before lutetium 617, when we do a PSMA PET, we often will do an FDG PET simultaneously. I know most people aren't doing that, but we will do that fairly regularly.
How does it influence your decision making? If you see a lot of stuff that lights up on FDG, and is it some sort of ratio, or is it just sort of a gut?
In this patient, it wouldn't influence my decision-making that much because he's pretty much had everything. But if a patient hadn't had cabazitaxel, let's say, and his FDG PET lit up, and especially it lit up in areas where the PSMA PET did not, that's somebody I'm going to lean more towards chemotherapy. That's how it's going to help me.
So here we have his imaging.
Okay, so you can see this was back in 2022. Early or late 2022, I think, when we wanted to give him lutetium, but we couldn't get it because of the shortage, and that was PYL. And then later with gallium-68, when we were getting ready to give it to him lutetium, a few months later, his PSA went from 119 to 144 there.
Okay.
And in this patient, I think the thing I want to point out is his PSA did drop with every cycle. You can see the imaging nicely got better. And I point out the fact that the things we look out for, we want to make sure that there's no renal tubular necrosis, the creatinine was stable, and we want to look to make sure there's no myelosuppressive issues. You certainly can get anemia, your white count can go down, your platelets can go down, and this patient did not have any myelosuppressive issues, but had a really, really nice response. And so I think this was, a pretty successful case.
I think that raises some important issues. What sort of side effects do you worry about? I mean, like salivary gland stuff and things like that?
So I mentioned the things that I worry about that I see in labs that the patient might not notice, but the things the patient will likely notice is that PSMA is expressed in the salivary glands and the lacrimal ducts, so they can get dry mouth, dry eyes. I do counsel all my patients. I ask them to use a humidifier. I ask them to avoid alcohol and tobacco. I ask them to avoid mouthwashes with alcohol in them that dry you out. I talk about xylitol, gums, xylitol little candies, things that can increase salivary secretion. So I do that counseling in advance.
Is that the last slide on this case? So I want to make sure we're running a little bit into the question answer period. We have a couple of other cases, but I want to give people an opportunity to ask questions. So if people have any questions, why don't you come up to the microphone and we'll focus on those first. And if nobody has any questions, we'll do a few more cases. There we go. I knew somebody would get up. 2 people. You don't have to run. We got plenty of time.
You want questions?
Yeah.
Great, thanks. Alistair Lamb, Bart's Cancer Institute, London. I was having a chat over coffee earlier. Often those of us from Europe find it so helpful to come to AUA, and we realize our blind spots. So perhaps in the UK, maybe in Europe more generally, we just assume full access to MRI and that it's self-evidently the right thing to do up front. We come over here, and it's not completely the opposite, but much more the case that you'd consider genomic tests, biomarkers, possibly Artera AI as self-evidently a useful thing to do up front. And the question is, where does MRI fit in your picture? So the question, I suppose, is more related to your first case rather than this one. Given a neutral playing field with no cost or accessibility limitations, what would be your ideal sequence in that case that you outlined with the PSA that was, so let's say they've got a PSA, although you could even put that to one side. Do you think that example that one of you shared with us from Andrew Vickers' paper about the different order of things, how would you sequence these tests, which all have their pros and cons?
Why don't I go first, and then Rob, you can go. So I think it depends on. So my sequence of events usually is to get an MRI. If the MRI is negative and I'm still suspicious, I'll get some sort of biomarker. And the problem with that is there's good data out there that shows that, yeah, you don't miss any Gleason 7 cancers and above, but you still biopsy 90% of the people. The other way to do it is to get the biomarker first and then only get the MRI if the biomarker is positive. The downside to that is, yeah, you'll miss about 10% of the Gleason 7 cancers, but you'll avoid the 40% of the biopsies. The group using the Stockholm 3 just did a really nice study where they did the Stockholm 3 test. You're now going to tell me you were one of the authors on that paper. No, good. So they did the Stockholm 3. That's a screening study that incorporates genetics and PSA and all this other stuff. If that was positive, then they got a 4K score. If that was positive, they got an MRI. And if the MRI was positive, they did a biopsy. And what you found, they're still following because they're worried they could have missed something, right? But you drive down the number of biopsies you need on the patient tremendously and makes a huge difference in a patient population, which I think is, you said you don't have to worry about cost. That's really where we worry about the cost, not in an individual, but in the population. I mean, we can't afford to continue to, I mean, I was only half joking about getting an FDG, a PSMA PET and an MRI in every patient. That can get really expensive really quick. So Rob, do you agree with me or do you disagree?
I think what I said is I don't know the answer because I think both ways of doing it make sense. There's good data for both, Precision Trial and others for MRI first. I think that really probably is the most common sequence of events. But I think there's pretty good data that starting with a biomarker. I think the problem we have is the biomarkers themselves are not always concordant. So they haven't been really well compared. So which biomarker to choose? I tend to use a urinary biomarker because it's kind of an analogous way of looking, it's an orthogonal way of looking at things versus just PSA or a PSA-based assay like 4K. But, as I said earlier, what I generally do is if I've got significant degree of suspicion, I go right to MRI. That's what we've been doing for 15, 16, 17 years. If I have maybe a lower degree of suspicion, the patient's all worried, I'll start off with a biomarker. It's easy enough to do. We have ready access to that, just like we do for MRI, and then only do an MRI or biopsy if that's positive. If it's greater than some threshold, which I come to an agreement with the patient about what that threshold should be.
Just one comment about what you said at the beginning, which I thought was going to be your question. I think in the United States and Canada, well, I don't want to speak for the Canadians, but I think it's pretty similar. Access to MRI is much better. It used to be the insurance companies would say no, but now they do pay for it. I think a little bit of it is basically geographic. If you go to rural areas of this country, there are big, healthcare deserts, and that includes good access to MRIs. And a significant portion of our population lives in those areas of the country since it's much more diffuse.
Might I just add one additional thing, if I may? I wonder if it's also fundamentally contingent upon what it is that we're aiming at. So is our greatest fear to avoid a clinically significant, inverted commas, cancer? Or is our greatest fear to overdiagnose and overtreat? Are we trying to avoid intervention, or are we trying to make sure we intervene wherever we need to? I appreciate the need to is important there. And in a system which fears most missing an important cancer, it might lead to a different answer to our initial question, to a system which most fears pathologizing the general population, where we might lead to trying to reduce our investigations and intervention.
I think you're probably right.
Well, you can see what I'm hinting at there.
No, I think you're probably right, though I would say I treat the 50-year-old, or I manage the 50-year-old very differently who's got a PSA of 5 than the 78-year-old who has a PSA of 5 that I wish nobody had ever drawn. I mean, do you agree with that? I think we have another question, and then we'll probably have to go to we want to make sure we do the follow-up question. So shoot.
I was just curious about the Decipher data. I thought that was very interesting. And what percentage of are you doing that on all your intermediate risk patients? And then how much of your grade group 2 are you putting on active surveillance?
Rob?
I'm not sure I completely, who am I doing Decipher on? Was that basically the question? So generally we're doing it, I'm generally doing it in grade group 2 and generally in men with, a low percentage of pattern 4, like 10%, 20%, because I place a lot of them on active surveillance. So if they've got a low decipher score and they've got less than 20%, let's say pattern 4, and no cribriform, no introductal, then we'll put that patient on surveillance, or at least we'll offer it.
I do the same thing, but also maybe high volume Gleason 6. I also tend to get a decipher on. Yeah, we'll have a bonus question because that was quick.
Hello, Dr. Barış. I'm from Koç University, Istanbul. I would like to ask, is there a maximum number of radioligand sessions you perform in a patient? Would you go as long as you have a PSA response, or do you have a maximum number of radioligand therapies unless you don't see any PSA increases? And if PSA makes a plateau, would you still consider to continue the radioligand therapies, or would you cease at that point when it makes a plateau? And the last question, would you consider any other radiological imaging modalities other than PSMA PET during the follow-up of radioligand therapy responses?
Evan, I think that's yours.
Take it. So first off, I want to clarify that I try not to do a ton of oligomet-directed therapy outside of a clinical trial. I know it's rampant. We're all doing it. There are a lot of academic centers where there are medical oncologists, radiation oncologists that are doing it. But I try to do it on a clinical trial. So on a clinical trial, it's usually outlined. And some clinical trials, like the OAST trial, allows you to re-irradiate so you could have a relapse and then go irradiate again. And so
radioligand therapy, I'm sorry.
I think he was asking about lutetium.
I'm sorry, I misunderstood.
He was asking about lutetium. He's essentially saying, how long do you treat with lutetium? If it naders, how long do you leave it on them before stopping the drug? And do you get any additional imaging while the PSA is...
I apologize. I totally misunderstood the question there. It's actually, for some reason, it's hard to hear things from this corner. So by the FDA approval, we're limited to 6 doses. Now, occasionally, some of my colleagues have been successful in getting additional doses and have been able to retreat. I have not ever been successful. When I live in the Northwest United States, the third-party payers are pretty uptight up there, so I haven't been able to do that. But the second part of your question is we generally do additional PET imaging on some of the studies, and we also will do SPECT serially on that. Now, there's not great data as to should we stop or not. But if I have a patient whose PSA has gone down and their repeat imaging looks like things look pretty darn benign and cold, they're starting to get xerostomia and side effects, that might be somebody where we would have a conversation about, do you want to stop? And it's easy to have that conversation since you're limited to 6 doses, right? We're not doing dosimetry, which we probably should be. There's complexities to doing that. But sometimes I've given like 2 or 3 doses or 4 doses, and patients having side effects or getting myelosuppression, and then I'm lengthening things out and waiting for PSA to rise, PSMA PET to look worse again before I'll dose again. So that's the art right there. It's not a perfect world. I don't have great data to guide us.
Okay. I want to thank all of you for coming. I hope you enjoyed the session and enjoy the AUA.